you to bring you today Dr. Monica Kraft, who is an internationally known physician scientist who specializes in clinical and translational research in airway disease. She is now the chair of the Department of Medicine here at Mount Sinai and the Icahn School of Medicine since July 2022. Previously, she served as the chair of the Department of Medicine at the University of Arizona College of Medicine in Tucson, as well as professor of medicine and Robert and Irene Flynn Endowed Chair in Medicine. Prior to joining the University of Arizona, she was the Charles Johnson Distinguished Professor of Medicine and chief the Division of Pulmonary Allergy and Critical Care Medicine, as well as the director of Duke Asthma, Allergy, and Airway Center at the Duke University Medical Center in Durham, North Carolina. Dr. Kraft completed her MD degree from UCSF and her residency at Harbor UCLA Medical Center, where she was also chief resident. After completing her fellowship in pulmonary critical care medicine at the University of Colorado Health Sciences Center, she joined the faculty as director of the Carl and Hazel Felt Lab for Adult Asthma Research and the medical director for Pulmonary Physiology Unit at the National Jewish from 1995 to 2004, from whence she was recruited to Duke University to create and direct the Duke Asthma Allergy Airway Center in 2004. In addition to patient care and caring for people with severe asthma and COPD and teaching trainees, she has published extensively in the area of adult asthma and COPD. Specifically, her research interests include mechanisms of innate immune dysfunction, inflammation, and infection in asthma, as well as the evaluation of personalized and precision approaches to asthma therapy through clinical trials. She was also the contact PI for the All of Us program at the University of Arizona. Her work has appeared in major medical journals, both general medical and respiratory and critical care and allergy journals, and her H index is 81. Her work has been continuously funded by the NIH and the ALA for 25 years, and she's been a member of and chaired several NIH study sections. She's also co-founder and chief medical officer of Raycedo Inc., a company created to develop peptidomimetics for the therapy of inflammatory lung disease. Dr. Kraft has received the Presidential Early Career Award for Scientists and Engineers, awarded by President Clinton at the White House in 2000. And she was also awarded the Distinguished Career Award and the Elizabeth Rich Award for mentorship from the ATS, and where she served as a president from 2012 to 13. She has received the Arizona Bioresearcher of the Year in 2019 and is a council member of the Association of Professors of Medicine. If I continue much further, we will not have much time to learn about the topic that she's going to speak on today. So the floor today is all yours, Dr. Kraft, and thank you for joining us. And welcome to the Institute of Critical Care Medicine.
Great. Well, thank you so much for that wonderful introduction. I wish my mom were here to hear that. And I'm going to just share my screen. Oh, that's not it. Let's see. Where did it go? There it is. Okay. All right. Let's get to. Can everyone see that? Good. Okay, great. Well, thank you for inviting me. I'm very excited to be here. And I'm going to be talking about asthma and precision medicine in 2023. Where are we? And I will say it's an exciting time to be in this field because the understanding of the disease from an immunologic perspective has just exploded really over the last couple of decades. And it has really resulted in some incredible opportunities and therapies that we can offer our patients. So it's a really great time to be in the field. So I'm going to give you sort of a little bit of a snippet of what we do, which is not necessarily all critical care focused, but I have to have a few slides on status asthmaticus, of course. We have to talk about that. All right, let me see if I can advance. Okay, oops, sorry. My disclosures are here. I do a little bit of consulting and actually I find it very useful to figure out what the pipeline is from some of these for therapies, and they often end up being opportunities for clinical trials. All right, so what I hope to talk about is the evolution of understanding of asthma biology and how it's impacted therapy, the use of biomarkers to delineate specific phenoendotypes of asthma, how can we do that in the clinical arena, and discuss how we can use these precision-based approaches to impact therapy. And then at the end, I'll talk about actually a study that we're doing called PRECISE, where we are employing these objectives. I'll start with a case. This was a former patient of mine when I was at Duke. A 38-year-old female with severe persistent wheezing on chronic oral steroid therapy, presented with increasing shortness of breath and worsening wheezing. Asthma was diagnosed at age 22, 1 hospitalization per year since her diagnosis, 2 to 3 exacerbations per year as an outpatient. She was intubated once for status and has been on oral corticosteroids intermittently and now chronically. Been treated for several comorbid conditions that you will see in a patient with asthma, including gastroesophageal reflux disease, allergic rhinitis. In this case, she has a history of nasal polyps and chronic rhinosinusitis, depression, and osteopenia. Her baseline symptoms, really even not in the throes of an exacerbation, are shortness of breath and wheezing with limited activity. She uses albuterol 4 to 5 times a day, which of course is way more than we would like her to, but she really does need it. And at the time, I really felt like she was adherent with her medical therapy. And that's of course a big issue for any chronic disease management, as we know. Her medical history is what I had mentioned. And she also has aspirin causes rash and wheezing, so she has aspirin exacerbated respiratory disease, or what we used to call Samter's triad, which is asthma, nasal polyps, and aspirin sensitivity. Her med list is what you might expect. This is a little bit older now, so some of these, although maybe alendronates, we don't use that as much, but really a lot of these we still use, especially in acute asthma. In this case, she was on Medrol instead of prednisone, as actually I have found some individuals are actually rapid metabolizers of prednisone and do better on Medrol. Of course, she unfortunately failed outpatient therapy, which is why she presented to the ED. High-dose fluticasone salmeterol, montelukast, albuterol ipratropium nebulizers, in addition to albuterol MDI, omeprazole, loratadine, fluticasone nasal spray, calcium, vitamin D, and alendronate. Her social history, she had outside cats. I'm not sure I really believe that because cats like to come in, but office work with no exposure, and she's a never smoker, mother with asthma and atopic dermatitis. On exam, she had a prolonged expiratory phase with some moderate air movement, which was good because sometimes, as we know, in the acute setting, if you're not hearing air movement, that's a very bad sign. So she was. And her biomarkers, which we'll talk a bit more about what these mean later, peripheral eosinophils were 350, which is actually very elevated on oral steroids because oral steroids tend to suppress some of these biomarkers, but that wasn't the case for her. Her exhale nitric oxide, which is something we can measure in exhale breath, was 40 parts per billion. So anything over 25 is suggestive of untreated inflammation. Her total IgE was 50, which is not particularly elevated, and her allergen-specific IgE testing was negative, and those are tests we had done previously. Her chest film, you can see she's got some flattened hemidiaphragms. Otherwise, cardiac silhouette is normal, trachea is midline, no signs of barotrauma at this point, and really no infiltrates. And we were able to get pulmonary function tests, so that's spirometry. And so at the time, her FEV1, of course, forced expiratory volume in 1 second, was 1.27 or 48% predicted. And this is predicted based on age, height, and gender, so significantly reduced. Anything below 80% predicted is abnormal. Forced vital capacity, which is what you can exhale in about a 6-second period of time, was 78% predicted, so relatively well preserved. But of course, that resulted in a significantly reduced FEV1 to FEC ratio consistent with airflow limitation, and a severe form of that, given that her FEV1 was so reduced. So what is asthma? It's a very heterogeneous inflammatory respiratory disease, actually the most common in the world, affecting over 350 million people worldwide, 25 million children and adults in the US. And the symptoms are pretty non-specific: chest tightness, wheeze, and shortness of breath and cough. And a lot of other lung diseases can cause these symptoms. There is no cure, and it can be fatal. And I think what sort of the perception is that most of us know someone with asthma if you don't have it yourself. And it's sort of perceived as a mild illness. You know, we just give them a little albuterol, they'll be fine. And I will tell you a funny story. I gave cardiology grand rounds a couple of days ago this week. It's my week for talks. And I got a nice email afterwards from one of our faculty. And they said, I had no idea asthma was this complex. I thought it was so simple. And so you'll see how the field has evolved from maybe what you might have learned way back in med school when it was thought to be just a disease of bronchoconstriction. And if you look at this cartoon, you can see the normal airway is nice and open. The asthmatic airway has sort of too much smooth muscle. And this is the airway epithelium, these cells that line the airway. And we used to think they were sort of, innocent bystanders. Well, they're nothing of the sort. They're very active participants in inflammation. And in the setting of an asthma exacerbation, of course, you have airway constriction with production of mucus from these epithelial cells that further causes airway obstruction. And that's really why patients die of asthma, is their airways are full of this inspissated mucus. And so speaking of that, status asthmaticus, I had to mention a few words about this. What's fascinating is when I look into the literature on this, it seems like very little has changed in terms of the approach to status. And so I'm hoping that over time, that some of the techniques and approaches we've learned in the outpatient setting in chronic asthma, we can translate to the ICU. And so certainly it's an asthma exacerbation resulting in respiratory failure. There's a couple of different kinds. And I think this is where I think the unmet need is in terms of understanding the different reasons why people end up with status. But it can be of a sudden onset, which may be neutrophil predominant associated with an overwhelming exposure, such as allergen, irritants, or NSAIDs, or slowly developing, which is going to be more of an eosinophil predominant issue, upper respiratory infection, or seasonal component due to allergy. Of course, the risk factors are previous episode of near fatal asthma, inadequate therapy, especially anti-inflammatory therapy, access issues, 2 or more hospitalizations or 3 ED visits within the last year, and those patients who use 2 or more canisters of a short-acting beta agonist, such as albuterol per month. Of course, the treatment goals are obvious: correct hypoxemia, reverse airflow limitation, decreased likelihood of recurrence. I think we'd all agree with that. The symptoms and signs: dyspnea, fatigue, of course, sitting upright. And our patient the patient that I described to you, in fact, was sitting upright. She was not diaphoretic or using accessory muscles yet, but eventually she actually did require admission to the ICU, but was not intubated for that admission, just FYI. Respiratory rate greater than 30, tachycardia, and of course a pulse of greater than 15 are also signs and symptoms you can see. And then of course complications are very concerning: tracheal deviation, subQ emphysema, asymmetric breath sounds. And lab values, if you can get them, and this is not always so easy in those critically ill asthmatics, if you can get a peak flow, certainly less than 30 to 50%, like in our patient who is 48% predicted, consistent with severe airways obstruction. If you do get a blood gas, certainly you may see mild hypoxemia and hypocapnia initially, but the PCO2 goes up when the FEV1 is less than 25% predicted. So it kind of gives you a sense of how ill they are if their CO2 is rising. And of course, radiographic studies really don't have a lot of role in the management, of course, unless you see signs of barotrauma, pneumonia in the setting of hypoxemia, and of course, anything localized on exam. The treatment options, it's interesting, haven't changed a whole lot in the acute setting. And I think, our fellows who do, who take care of patients, whether it's on in the wards or the ICU, they don't really realize that there's a lot of nuance to asthma. And hopefully by the end of this talk, you'll see why. Because of course, we're still using, beta agonists, either nebulized or MDI, IV corticosteroids, anticholinergics. Magnesium is something I know can be helpful, especially in the ED setting, to relax smooth muscle. Seems to have a preferential benefit in women, at least that's what the studies suggest. Heliox is something that is not used as often, but it decreases airway turbulence and work of breathing. It's used a lot in the setting of upper airway obstruction, such as vocal cord dysfunction, but there are a few studies where it acts as a bit of a bridge, especially maybe to avoid intubation until the steroids kick in. Non-invasive positive pressure ventilation is much more widely used in COPD versus asthma, but can be used depending on how obstructed the patients are, especially in the early phases of acute asthma. Later on, not so simple. And then of course, mechanical ventilation. So I'm actually going to switch gears. So I had to say a few words about the ICU, but wanted to really talk more about chronic asthma so that we can maybe keep these people from coming to see you, but then you're going to see them on some different medications if they do make it to you. And that way you will have heard of them. And so the treatment of chronic asthma has changed quite a bit. Used to be, we would give them an albuterol, maybe an inhaled steroid, and hope for the best. But there's a whole approach now using guidelines called GINA, which is the Global Initiative for Asthma, that are updated almost yearly. And it was put together by the WHO and NHLBI back in the 90s. And it's a very nimble set of guidelines for asthma that are extremely useful. And if you are interested, the website has a pocket guide, it has slides you can download, as well as the big PDF tome, depending on your interests. Good bedtime reading. But the diagnosis of asthma, of course, is based on variable respiratory symptoms and variable expiratory flow limitation. So lung function can be normal in the setting of asthma, but then the lung function undergoes a circadian rhythm. So depending on the time of day that you might measure lung function, it can change. Say from 4 a.m. to 4 p.m., it can be 20 to 30 to 50% different, depending on the control of that asthma. And so another feature is this airway hyperresponsiveness, which is this airway twitchiness. So for instance, on a cooler day like today, if you have asthma, you go outside, take a big breath, you might feel chest tightness and cough, and that's that airway twitchiness phenomenon. And that's a fundamental characteristic of asthma. And so, so I'm going to show you a little bit about how we look at asthma now, but at the global level, really the focus that we're really moving in, especially in the primary care setting, is to do spirometry, because you can't really diagnose asthma without really seeing variable or reversibility with albuterol. You want to see an improvement in lung function, ideally after withholding bronchodilators. Sometimes it's more challenging to show that if patients are already on controllers like inhaled corticosteroids. Oftentimes you need more than one test. And so the treatment guidelines have changed a little bit, and now there are two tracks. And I just wanted you to be aware. The track that's actually preferred is one that's been in place in Europe for, I'd say, a decade. This is using an inhaled steroid formoterol combination. So we would know these drugs as Symbicort and Dulera. Formoterol is a long-acting beta agonist. In contrast to Advair, where salmeterol is the LABA, formoterol is a complete agonist and is felt to be a bit safer using it as needed compared to salmeterol. So it's only the ICS formoterol combinations that are recommended. And these are used as both controllers and relievers. So patient has one inhaler, they use it maybe twice a day. And then if they need albuterol, they don't use albuterol, they use this. So every time they need something for acute symptoms, they're getting a long-acting beta agonist and an inhaled steroid. Now, the problem with that in the US is there was a person at the FDA who for years really felt that long-acting beta agonists were unsafe. And that in fact, it spawned 4 huge clinical trials funded by pharma to look at this. And I was on the DSMB for these trials, and it all ended up that if the long-acting beta agonist and the steroid is in the same device, it is very safe. Back in the old days when they were in different devices and people would only use the LABA, that's when complications would occur. But if they're in the same device, we're good to go. He's no longer part of the FDA, so that's actually probably a good thing. And so, but these types of guidelines have not been really implemented in the US. Part of the reason is insurance carriers haven't really come around to funding 2 inhalers per month, because if you're going to use it on a schedule and as needed, you're going to need more than one. So I'm actually trying to work at this at the policy level to really help carriers understand that this is part of the international guidelines and therefore should be covered. That's going to take some time. Now, we do it in the US, we use a short-acting beta agonist like albuterol as the reliever, and then we give patients a separate inhaled steroid. So that problem with that is that's not ideal, and I'll explain why in a minute, because patients tend to rely more on their short-acting beta agonist and don't realize that they need to use that controller, that inhaled steroid, every day on a schedule to get maximum benefit. So a lot of time needs to be spent in the clinic really emphasizing that point so patients know what to expect. And so I'll show you the issue is there's been now data suggesting that using a short-acting beta agonist alone can actually affect the airway long-term. And there's a realization that even patients with very mild asthma can have pretty severe exacerbations, and the triggers can be unpredictable. And so using an albuterol alone isn't ideal. And there are risks associated with mild asthma, and even 4 to 5 lifetime courses of oral steroids increase the risk of osteoporosis, diabetes, and cataracts. And I think now we're actually doing that. We're actually counting up sort of lifetime prednisone exposure to really understand what a patient's risk is. And even 1 course of OCS increases the risk for sepsis. So I found those data pretty astounding. So in 2019, a fundamental change came around with the GINA guidelines that regular use of albuterol is no more. that shouldn't happen, that in fact, even for 1 to 2 weeks can be associated with increased airways hyperresponsiveness, reduced bronchoprotective effect, increased allergic response, and increased eosinophils. Inhaled short-acting beta agonist has been first-line therapy for asthma for 50 years because asthma was thought to be a disease of bronchoconstriction. You'll see in a little while that it's much more than that, and that it can, and that the role of the short-acting beta agonist is reinforced by rapid relief of symptoms at a low cost. But the problem is overuse is associated with increased exacerbations and mortality and patients on their way to visit you. And so starting treatment with an albuterol trains the patient to regard it as their primary asthma treatment. And so what we suggest now is if patients are going to use their albuterol, they should also use a puff of their inhaled steroid. The problem is when they're in two separate devices, a lot of times patients won't do that. So the good news is there has been a combination inhaled steroid, albuterol, budesonide, and albuterol approved in the US. So that actually at least offers some hope that maybe we can put a bronchodilator together with an inhaled steroid that can be used as needed. And I'll bet you that will take hold probably before the ICS formoterol combination is my hypothesis. So these are the two tracks. So the preferred one is if a patient has symptoms less than 4 to 5 days a week, they just use as needed low dose ICS formoterol. And as they move up the steps, they have more symptoms, then they start using it on a schedule, and then they also use it as needed, and then, and then when they get to step 5, that's what I'm going to be focusing on in just a bit. And that's where we really use our precision medicine-based approaches. In the US, we're using a separate inhaled steroid and albuterol, not my favorite. And the idea is really emphasized to patients to take an ICS whenever an albuterol is used. I'll be honest, as I said, I don't think that happens as often as I would like, but I really try to spend a lot of time educating patients on the rationale for doing this. And then when that combination is available and covered by insurance, that will be a good day. All right, and so the idea is you're always assessing, adjusting, and reviewing. And one of the key things is you got to look for modifiable risk factors, comorbidities, simple things like inhaler technique. Sounds basic, right? But boy, a lot of $1 million workups have been avoided because of things like maximizing inhaler technique. And of course, patient preferences and goals, because it is part of a shared decision-making model. And so when I think about comorbidities, just like the patient I presented today, I spend a lot of time on this because it adds to medication burden and actually can make the asthma very difficult to control if you don't address them. So our patient had sinusitis with nasal polyps, very common, obstructive sleep apnea, increases vagal tone that can enhance bronchoconstriction. Vocal cord dysfunction is actually upper airway dysfunction that we treat by speech therapy and not with medication. We have great ENTs here who, by the way, are interested in voice and laryngeal function. So I've already partnered with them because my goal is to stamp out VCD in the Northeast. That's one of my goals. And gastroesophageal reflux disease, of course, acid and non-acid reflux are problems. Just having acid in the esophagus can trigger the vagus and enhance bronchoconstriction, but non-acid reflux can make its way all the way up to the larynx and even down into the lungs. It can be a very serious event. And then obesity is its own problem because it can make certain asthma phenotypes worse and then create its own phenotype. And I'll explain that in a little bit. I'm not an allergist, but I've learned a lot from my allergy colleagues about the role of allergen and environmental exposure. And I do a very detailed allergic history. And then we get an asthma profile here where we can look for specific IgE in blood to certain allergens. Smoking, about 20% of asthmatics smoke. And I do see patients who've had asthma, smoked, and now developed COPD. So there is this overlap, and they can be a very difficult group of patients to treat because they tend to have a lot of exacerbations. Alternative diagnoses, I'll mention that in a minute. Psychological factors such as anxiety and depression, non-adherence, of course, and then drugs, aspirin, non-steroidals, beta blockers, and ACE inhibitors. I saw a patient a week ago, about 2 weeks ago now, who was referred to me who had unaddressed sinus disease, sleep apnea, and reflux, and was on a beta blocker. And it was amazing to me that another pulmonologist referred him to me without really looking at all those things. So again, just emphasizing the importance of why potentially his asthma was not doing well. Now, there are other comorbidities that you can see in asthma that look a lot like COPD: hypertension, We already talked about OSA, diabetes, osteoporosis, coronary artery disease. And these data from the Severe Asthma Research Program suggest that the more of these comorbidities a patient has, the greater the likelihood of having multiple systemic corticosteroid bursts over 12 months. So there is this unfortunate synergy, and it's important to recognize these comorbid conditions and address them. So these are some masqueraders of asthma. You can't have a talk about asthma without talking about this. COPD, of course, being the big one. Panic attacks, bronchiolitis, congestive heart failure. I took care of a lovely patient back in my days in Denver he came into the exam room, and I heard him, I walked into the exam room and he was wheezing across the room. He's about 80 years old. He needed a new mitral valve. So that was one of my 2 asthma cures. The other one was when the cat died. So I have 2 to my credit. And so he was so cute because I thought he would be happy that we had a treatment for his, profound, lung symptomatology. And he was so cute. He goes, "Doc, can't you just give me a shot?" I said, no, we unfortunately have to replace that valve, but then you will be a happy camper. Adverse drug reaction, of course, another one. ACE inhibitors, of course, as I mentioned. Bronchiectasis and CF can overlap. And then these are less common, but one I like to mention is PE can actually present with wheezing. So not to forget about that, because not all that wheezes is asthma, we like to say. And then this last entity, formerly Churg-Strauss, it's now called eosinophilic granulomatosis with polyangiitis. We say EGPA because we don't feel like saying that whole term. That's asthma with a vasculitis, and that's a very severe form of the disease. All right, so let's move into the more severe asthma and talk about some terminology. There's uncontrolled asthma. So that's actually asthma that can be of varying severity, even mild, but have a history of frequent flare-ups or exacerbations. There's difficult to treat asthma, not difficult patients. That is asthma that's uncontrolled despite high-dose controller therapy, like high-dose inhaled steroids. The reasons for that may include incorrect diagnosis, incorrect inhaler technique, poor adherence, or the presence of comorbidities that haven't been addressed. Severe asthma has had many different meanings, and this is what I'm going to be talking about. It's defined as asthma that is uncontrolled despite maximal optimized therapy, treatment of contributory factors, and or that worsens when high-dose treatment is decreased. So that's really what the kind of asthma I'm talking about, and is relatively refractory to corticosteroids. Okay, so how do we address this in 2023? Well, precision medicine approaches really involve the use of what we call phenotypes, which are collections of clinical characteristics. It can be symptom onset, early, late, exacerbation history, lung function, the kind of inflammation, and I'll talk a little bit more about what that means. And so it's the observable characteristic of a disease. Some examples could be allergic asthma, aspirin exacerbated respiratory disease, severe eosinophilic asthma. The holy grail really is to figure out the endotype, which is the mechanism driving that phenotype. And the good news is in our space, we have some therapies that actually target specific inflammatory pathways that we can offer. So that's good. And then we use biomarkers to figure out what kind of a phenotype our patient has. And what we use most commonly these days are blood eosinophils and this exhale nitric oxide, as we talked about with our patient, as well as IgE and allergen-specific IgE. I wish we had a few more biomarkers at our disposal. There are several under development because I think we still have a ways to go to be just a little more sophisticated in our phenotyping, and you'll see why. But in 2023, what we do is we divide asthma into 2 buckets, type 2 and non-type 2. So type 2 asthma means there's a certain kind of inflammation associated with it, and it's really all about the eosinophil. That's the best thing to remember. If you don't remember any of the cytokines, it's okay, but it's the eosinophil. But our favorite cytokines for type 2 asthma are interleukin 4, 5, and 13. And as you'll see, we have biologics that actually inhibit those, so that's good. But under that type 2 umbrella, there are some subphenotypes. There's the early onset asthma that's mostly atopic and probably the most common kind of asthma you might think about. There's a strong history, a family history of atopic disease. It can overlap with other atopic conditions such as allergic rhinitis, atopic dermatitis, and it can be progress from mild to moderate to severe disease. And so it can be the whole spectrum of severity and can be exacerbated by obesity. And then under that type 2 umbrella, we have a later onset like our patient. Hers presented at age 22. So we're talking about presentation in the 20s. And just so you know, asthma is more common in boys and children. Tends to get better in everyone during those teenage years. But if it's going to come back in the 20s, it's more commonly presents in women. And about in this late onset asthma, this can be a very difficult kind of asthma to treat. Lots of eosinophils, lots of sinus disease, oftentimes nasal polyps, very little allergy, very little atopy, and exacerbated by obesity. Obesity very common in this subphenotype. Non-type 2 asthma, it's about the other half, because type 2 is about 50 to 60% of all the asthma, but then we have this non-type 2, and I would say this represents the biggest unmet need. And so really, there aren't a lot of eosinophils around. You may see neutrophils, and you see lower lung function, air trapping, thicker airway walls. There's a linkage to obesity that actually creates its own phenotype of non-type 2 asthma associated with high interleukin 6 levels. And there's associations with infection, environmental exposure, such as ozone pollutants, and of course, cigarette smoking. So the take homes about the endotypes. So T2 asthma, type 2, T2, T2 high, you might hear all those terms, more severe, does respond to corticosteroids, but maybe not completely, and in response to inhibitors of type 2 inflammation. Non-type 2, T2 low, poor response to corticosteroids, higher association with fixed airflow obstruction, reduced responsiveness to inhibitors of type 2 inflammation. And here's this little schematic that I've adapted for our purposes today. So you see this type 2 versus non-type 2, little circles here. This is aspirin exacerbated respiratory disease, this allergic asthma, which is that early onset we talked about. There's actually two kinds of late onset, but for the purposes of our discussion, anything 20s and over would be considered late onset. Now, exercise-induced asthma can be its own subphenotype, and I have actually gotten referrals from athletes over the years, very high-performing elite athletes who at peak exercise develop significant respiratory symptoms. And so the question is it asthma, lower airway disease, or is it upper airway dysfunction? And so, so that's been a very important area for my practice. But exercise can actually exacerbate any of these phenotypes. So then we move over to non-type 2. We see this smoking-associated neutrophilic. What I didn't mention is there's a type of non-type 2 asthma that has no inflammation, just has a lot of smooth muscle hypertrophy, a bit of collagen deposition, no inflammation. I'd say we know the least about that subphenotype. And then, of course, pollutants and infections that I mentioned. And then obesity, I sort of tried to straddle it between the two because it can make these type 2 phenotypes worse or create its own phenotype, as I mentioned. All right, so you can't have a talk about asthma without showing this, and I'm only going to do a couple of these because these usually put people to sleep. But, sorry. It's very finicky. Let me go back. There we go. So type 2 high, what I want to emphasize in this is that the epithelium, which is those cells that line the lung, no more innocent bystanders, extremely involved in the inflammatory response, and they produce these mediators over here, TSLP, IL-33, IL-25. And the reason that's important is the first two actually have inhibitors that are either approved or being evaluated right now. They work with dendritic cells and T cells, ultimately to produce IL-4 and 13 and 5 that bring eosinophils into the airway. So that's the type 2 high. Type 2 low, you'll notice it has the same triggers: irritants, pollutants, microbes, viruses, maybe not allergens, but there's a whole host. There's some familiar, there's some similar, TSLP, IL-33, but now you're seeing IL-6, TGF beta, IL-8, and it really is all about the neutrophil. And the next slide just really amplifies this a bit. And so these epithelial products are called alarmins, and they are what is really responsible for, they're triggered in the setting of these environmental insults. And they really do regulate T cell responses and ultimately affect your cell influx into the airway, like the neutrophil or the eosinophil, depending on the kind of asthma that one has. And so there's this T2 low disease, as I mentioned, is a bit of a black box, but we've made some strides. And so just a couple of words on the kind of inflammation we might see in T2 low. And the reason I mention this is because there's some druggable pathways here. There's certainly IL-1 beta made by the macrophage. There are studies going on looking at IL-1 beta. CXCL8 is actually IL-8, which brings in neutrophils. There's studies going on with IL-8 inhibitors. IL-17, which brings in the neutrophil. There've been actually studies looking at IL-17 inhibitors. So trying to gather some steam in this non-T2 space. And it's because the immunology of this disease has really exploded. And then the last slide I'll show, like this, and then that's it, is just a few words on IL-6. And the reason I mention it is it can create its own subphenotype associated with high IL-6 levels in blood, obesity, and metabolic syndrome. And in fact, you may see a neutrophil predominant type of inflammation with that kind of asthma. That can be a very difficult to treat asthma. But what IL-6 can do is it depends, depending on how it signals, if it actually associates with its receptor on a cell or a soluble receptor in blood, it can actually affect the airway epithelium to cause compromised barrier function and IL-33 production to bring in the eosinophils. And the reason I mention that is because the patients with asthma who have both neutrophils and eosinophils have the most severe form of asthma of all. Okay, we're done with that. So if you have a patient right now who doesn't have eosinophils, what can you offer them? So you're going to check eosinophils. You might look at sputum if you can, and that actually can be valuable to look for neutrophils, to be honest. And then you can look at exhaled nitric oxide. If they are high, if blood eosinophils are high or FeNO is high, sputum eos are high, then you've got this type 2 high asthma, and I'll show you we have lots of choices for those patients. If these biomarkers are low, then you might have type 2 low asthma, which we don't have as much to offer. But the key thing with this asthma is we need to do some other studies. So we need to look at smoking history. We might actually want to look for occult infection. I use sputum culture and bronchoscopy in my own practice, and there have been patients who have asthma whose BAL will grow staph, Pseudomonas, Moraxella, Haemophilus as examples. You treat those particular bacteria and the asthma can melt away. It's a beautiful thing. So there really is this interesting association with infection and asthma. And also other diagnoses to think about: non-tuberculous mycobacteria, cystic fibrosis, ciliary dyskinesia, bronchiectasis, primary immune deficiencies, and of course COPD. So you've got to rule all those out and then to really decide if you truly have low neutrophilic asthma, because there are many other things that can mimic that. And then if you do have it, what do we give to patients besides it? Because they don't really respond that well to inhaled steroids. So we tend to try it, and if they don't respond well, we try to either stop it or keep them on a low dose just because of the side effect profile. So what we use in this group is we can use low dose azithromycin 3 days a week, which has been shown to have an effect. There are a couple of biologics, which I'm going to tell you more about, one that inhibits the IL-4 receptor that can be beneficial, and one that inhibits that TSLP from that airway epithelium I was talking about. That also has benefit in this type 2 low asthma. For those of you who are familiar with bronchial thermoplasty, I mention it here to be complete. We don't do this as much. If you've never heard of it, it's actually applying radio frequency heat to the airways via bronchoscopy. It decreases the smooth muscle layer. And there actually have been some very nice responses in the right patient, but the side effect profile is profound. And it's not in the guidelines. When the severe asthma guidelines came out, the recommendation was to consider this under the guise of a registry or in a clinical trial. All right, so what can we do in the clinic these days to figure out what kind of asthma a patient has? Well, as I mentioned, we can look at sputum eosinophils, but it's not so easy to do. My lab does it. The processing is a little bit involved, and so most clinicians don't have access to this. We can use exhaled nitric oxide, circulating eosinophils, total IgE, allergen-specific allergen-specific IgE, as I mentioned. Okay, wow, sorry, this really is finicky. I apologize for this. Okay, there are two, so when I want to use the mouse, it seems to flip the slide. There are two biomarkers under development, just to let you know about. Eosinophil peroxidase, the Mayo Clinic Scottsdale people are working on this. It's a throat swab that measures peroxidase, which is what eosinophils release when they are degranulating. And that actually correlates very well with lung eosinophils. And then urinary bromotyrosine, which is also reflective of type 2 inflammation, eosinophilic inflammation, and the Cleveland Clinic folks are working on that. So nice to see that there's some more biomarkers under development. I'm actually working with a company right now who has a very interesting next-gen sequencing approach to really do some more involved immunophenotyping, looking at specific cytokines, et cetera, beyond what I've mentioned, and to look at the microbiome, because that's a whole half of this that I'm not talking as much about today. And to get a sense for both would be amazing in terms of our level of sophistication in phenotyping our patients. So we're involved in a small business grant to look at that approach to phenotyping. All right, a couple words about blood eosinophils. We look at absolute numbers of eosinophils, so anything above 150 is worth noting. It's associated with this type 2 inflammation I was telling you about, IL-4, 5, and 13. So blood eosinophils pretty much mirror the lung, but they're not an exact correlation. And blood eosinophils undergo a circadian rhythm, so they're going to be higher in the morning, early morning, than in the afternoon, for instance. So it's important to realize that when you're measuring these. But nevertheless, we use them, and I'll show you how we do it. Exhale nitric oxide, our patient had 40 parts per billion, so she was in the medium range, but that was on oral steroids. So I think that was pretty impressive. I had a patient the other day whose FeNO was 79, so they can be very high. And this is indicative of really IL-13, IL-4 and 13 induced inflammation. And so, so it tells you that there is untreated inflammation in the lung of a type 2 variety. So that's very handy to have as a point of care biomarker in the clinic. We can do that on all of our patients, which I do. IgE itself correlates with the diagnosis of asthma, but doesn't necessarily change in terms of response to therapy or severity so much. So it's not a great biomarker. We use it if we're thinking about omalizumab Xolair, which binds to IgE, if we're thinking of using that as a biologic. That's where that comes in. So what can biomarkers tell us? Well, there's diagnostic biomarkers such as IgE, blood eos FeNO, lung function. There's prognostic, assessing severity like lung function, and then predictive, when we want to add a biologic, blood eos and FeNO. And identifying, as I mentioned, endotypes is particularly useful in predicting response to therapy. All right, so right now we have what I call kind of an embarrassment of riches. We have 6 biologics at our disposal for treatment of severe asthma. And these are patients who, again, are on high dose inhaled steroids. They're usually on another controller like Spiriva, Alama, and they're still having exacerbations. You've addressed their comorbidities. And so one of them, omalizumab, was the oldest. It's been around for about 20 years. It binds to IgE and takes it out of circulation. So it's for that patient who has lots of allergies as a big driver of their asthma. Then we have 3 that inhibit this interleukin 5 cytokine. 2 of them inhibit the cytokine itself, 1 inhibits the receptor. We care about IL-5 because it's responsible for eosinophil survival and trafficking. So if you get rid of IL-5, you get rid of EOs. So that's a good thing. One of these is IV. The first one, reslizumab, is an IV form, so we don't use it as much. Then the next one, dupilumab, you've probably seen that on TV. They do a lot of direct-to-consumer advertising. That focuses on the IL-4 receptor, and you inhibit IL-4 and 13, number 2 of our favorite type 2 cytokines. And then the newest one, tezepelumab, they're doing a lot of advertising as well, I've noticed. That inhibits TSLP, and that's that epithelial product I was telling you about, very high up on the inflammatory cascade. And that actually works in type 2 and non-type 2 asthma. So the only biologic that works in non-type 2 asthma. So that's helpful for somebody like me, because it was wonderful to have something to offer my non-type 2 asthma patients. So as you know, eosinophils can be a component of allergic and non-allergic asthma, and this just tells you where these biologics work. So tezepelumab works up here, there's TSLP, omalizumab's binding to IgE, which is on the mast cell, dupilumab is getting IL-4 and 13, coming from the T cell, benralizumab is binding to the IL-5 receptor on that eosinophil, and then mepo and resli are binding to the IL-5 cytokine itself, just so you know where these work. All right. So how do we know what biomarkers are useful to determine which one of these to pick for your patients? The bottom line is blood and FeNO are probably the best. Sputum, there was a study that suggested sputum eosinophils were really good to predict response to mepolizumab, but in general, we use blood and FeNO. You notice IgE isn't here at all. IgE isn't really useful other than to do weight and IgE-based dosing for omalizumab. All right, so do these biologics ever get compared head to head? Well, they hadn't been, and that's been one of the challenges. But there is one study called Predictimab, kind of like that name, and it's comparing omalizumab, the anti-IgE, with mepolizumab, which is an anti-IL-5. So patients who are eligible for both get put on one, and then they switch to the other, and then they can be either prolonged or switched depending on clinical response. So that's recruiting now, and that'll be nice to see that they're two very different biologics. It'll be really interesting to see the response in patients head to head. All right. So the last part that I'll talk about is how do you decide on what a patient should be on? And so I am a section editor for Up to Date, and so developed for severe asthma, developed an algorithm with Paul Diefenbach from the Brigham and Sally Wenzel from University of Pittsburgh, using all the data we have available today. So this is sort of the thought process we go through, and this is what I teach our fellows, and I teach faculty who call me, and I go to national meetings and talk about this, because this is where the rubber hits the road in terms of really picking the right biologic for the right patient at the right time. So of course, like we talked about, you know if they have severe asthma, you have taken care of their contributing factors, you've done all this phenotyping through perennial allergen assessment, EOs, pheno, IgE, and then there are a couple that actually are approved for other comorbid diseases. For instance, if your patient with severe asthma has atopic dermatitis, then you get to pick dupilumab. That's easy. Then your decision's easy. If they have this EGPA with this vasculitis, then mepolizumab is approved. If they have nasal polyps, you have a couple of choices. You can go with dupilumab. Second line would be omalizumab in childhood onset asthma, mepolizumab in adult onset asthma. So that's if they have another comorbid allergic disease. If they don't, then you really have to look at their eosinophil count. So if they have a low eosinophil count, less than 150, if their pheno is elevated or they have any sensitivity to allergens, then you can go with this omalizumab. If they don't, then you go with tezepelumab, because you have that non-T2 asthma I was telling you about. Okay, and there's alternatives. And now one thing I will tell you, this is not an exact science, that patients often have partial responses to these biologics. So we try our best. That's why I was saying we need more biomarkers and our ability to be more sophisticated around phenotyping, but we're not too bad. I'd say we're ahead of some fields. I think we have a little more work to do, but that's because I'm right in it. So I know the pluses and minuses. If you have EOs about 150 to 300, the idea is dupilumab is a good choice. You could also use tezepelumab. If your EOs are really high, 300 to 1500, then you start thinking about when the asthma shows up. If you've got childhood onset asthma, the preferred is dupilumab. If it's adult onset asthma, then it depends on whether or not they have other markers of type 2 inflammation. If they do, then you stay with it. If they don't, you go with the anti-IL-5s, are the best for really high eosinophils. And then the last category, if they're really high, you've got to worry about hypereosinophilic syndromes, other diagnoses. And if they have that, you treat for those. And if you don't, you'll use the biologics that inhibit IL-5. All right. And then of course you evaluate efficacy over 4 to 6 months. And then if they aren't really improving, and the main improvements that you'll see are lung function and really exacerbations are the holy grail. So it's usually for those patients that are having frequent exacerbations that benefit the most from these biologics. Okay, the last thing I want to talk about before I finish is the PRECISE trial. I wanted to mention a few words about this. We're doing this. This is an NHLBI funded trial. It's a consortium, a national consortium. I can't believe it was founded in 2017. COVID has slowed us down a couple of years. We should have been done by now, but we had to stop for almost 2 years, but we're back in action. And we're all around the country, as you can see. And so I was actually in Arizona when I wrote the grant with Wake Forest and Mayo Clinic Scottsdale. And thankfully, National Jewish and Denver, University of Colorado are part of it, as is Mount Sinai. So I got to continue, and I work here with Linda Rogers on that project. And Roz Wright is also part of it too. And so the idea is to identify novel therapies that work in biomarker-defined subgroups of severe asthmatic adolescents and adults. And so the idea here is there's 5 novel interventions, and it's using an adaptive platform design. I'm not sure if you've all heard of that before, but it's the idea that you have multiple interventions. So participants come in, they're well phenotyped, they go into one of 5 interventions, they'll go through a treatment phase of 4 months, then they'll go to a washout, then they'll go to another therapy for 4 months, and then go through a washout, and then get a third. So they can get up to 3 different treatments in the study, which I think as a patient with severe asthma, I would think that would be pretty attractive. One of them can be placebo. So, but only one maximum. Now, as the trial's going on, real-time data analysis is occurring to find out who the responders and non-responders are based on clinical characteristics. And if you have an intervention that just doesn't work in anyone, it's pulled out and another one's brought in. So it's a very dynamic study. And this has been used in the oncology space for years, and this is the first time we've used it in respiratory. And the endpoint is it's a composite endpoint of lung function, symptoms, and exacerbations. So this is just a schematic of how it works. You have a run-in, treatment A, and then a washout, treatment B, and treatment C. And we collect a lot of different biomarkers, as you can see here, symptoms, as spirometry, blood, of course, for eosinophils, IL-6 neutrophils, DNA, etc. Exhale nitric oxide, sputum for lots of mediators, including EOs, IL-6 neutrophils, and also lots of cytokines in the supernatant. Exhale breath condensate and CT. So a very rich repository is being built because we're recruiting about 600 patients. The treatments are not what I've talked about today at all, and you can be on biologics to come into the study. So if you have patients or you know of somebody who has severe asthma, whose asthma is not doing very well, maybe is maximally treated, you're just not sure, let Linda Rogers or I know, and we're happy to take care of them, whether or not they qualify for PRECISE. And so we're using a couple of different interventions. I mentioned IL-6 a lot today. We're looking at an anti-IL-6 that we repurposed from rheumatology to see how it works in that one phenotype I mentioned of the obese patient with metabolic syndrome. Oops. Imatinib is a c-KIT inhibitor that has effects on the mast cell. Medium chain triglycerides actually has a weight loss aspect to it, and we think it works best in those patients who have elevated nitric oxide levels. Bronchovoxome is actually a bacterial lysate of gram-positive and negative bacteria approved in Europe for over 20 years to ward off respiratory infections. Turns out it has some really nice effects in asthma and some single center trials. Actually reduces exacerbations, also affects T regulatory cells to increase them, and Tregs kind of put the brakes on inflammation. So that's a nice thing. Cabazonstat is a drug that inhibits an enzyme in that airway epithelium that promotes bronchoconstriction. So we think they're pretty novel interventions. They're all sort of phase 2 trials, so they're not yet approved for asthma, but they've been used many times in single center, and now they're coming to the multi-center stage. So the bottom line is patients who are on high-dose medications for severe asthma, and they've either had an exacerbation in the last year or have reduced lung function or poor symptoms, they can get in. So the inclusion-exclusion criteria are pretty liberal. The biggest one is they can't have smoked. They can't have smoked much at all, and that's or vaped. And so that, you can imagine, can be a challenge across some of our potential participants. And so that's probably the biggest barrier, one of the biggest barriers we've seen. So if you have anyone that you think you would that might be interested in the trial, or who has severe asthma that just needs another opinion, please let Linda or I know. She does know I'm telling you this. So our approach to asthma is changing because it's so heterogeneous, but we've also really we understand the immunology so much better that has translated to really amazing therapies that we have. And we also have changed even treatment of mild to moderate asthma using what we call the SMART therapy. This is the ICS formoterol, using a controller reliever combination on a schedule and as needed to really simplify treatment for our patients. And then 6 biologics approved in the US. And the use of clinical characteristics, biomarkers in response to treatment, I think, will further hone our ability to deliver personalized precision therapy. So with that, I'll stop, and I want to thank you for your attention. Oops, I'll stop sharing.
Thank you for that whirlwind tour of new asthma, at least for a lot of us. I'm going to hand this over to Dr. Dua to launch the Q&A session.
Hi, thank you, Monica. Thank you so much for that. That was such a grand overview of everything new in asthma, and never get tired of hearing about it.
Well, I'm glad to hear that.
And I want to thank Doctors Gidwani and Liebner for converting this back from a webinar to a Zoom, because they must have heard me whining about the webinar format, because or interact with anybody. So I'm so glad we went back to Zoom format. So I don't see any questions in the chat, but I actually had learned something new today. The IL-6 piece in non-TH2 asthma, I didn't know about before. And the very fact that you're studying TOSI, which I'm sure a lot of our critical care guys know it very intimately, thanks to COVID trials. very excited to hear you're working with that. What have you thought about combining biologics if you ever,
Oh, no, I'd love, oh yeah, great question.
right? Yes.
Yes. I'd really like to, because in a perfect world, I'd love it if patients didn't need steroids at all. Because especially high dose inhaled steroids over time, even in the short term, patients have weight gain and thrush and voice changes. And over the long term, the side effect profile is pretty darn significant. And so I'd love to have combinations of biologics that target specific pathways and we can get them off their steroids. That would be my dream. The challenge is these are very expensive drugs and getting them approved is no small task. As a matter of fact, I had an interesting experience. Really, I'm in the midst of it right now. So tezepelumab is the newest biologic that has a benefit in non-type 2 asthma. It's the only one. And I have a patient who had a very severe exacerbation. She's non-type 2 after multiple checks of her biomarkers. So I ordered it. Her insurance company says, well, guess what? She has to fail another one in order for her to get Tezi. And I said, but she doesn't qualify for any of the other ones. They don't know that little fun fact. So we're doing appeals and I need to get a peer-to-peer. I got to talk to somebody and figure out, because they likely probably don't know a lot of this stuff. And so I just need to get them on the phone and hopefully I can convince them to approve this for her, because I don't feel like I have a lot of other things to offer other than I guess you could come into the PRECISE trial. But so what I do now is if I am switching biologics, I'll try to start the second one as the first one is still on, as we're sort of taking it away to kind of look at the benefit of both. I did have one patient on 2 because he got one from the VA and then one from me. Don't tell anybody. Yeah, and so that was actually great. He really responded very nicely. It was actually omalizumab and an anti-IL-5 because they inhibit very different pathways. So so that's about as far as we've come in 2023 with that. But it's a good question. I get that question a lot because that's kind of where we'd like to go.
Eventually. Great. Thank you very much. I don't see any other question in the chat box, and I know these guys have another meeting at 2, so
Awesome.
Monica, thank you so much for that.
Thanks for having me. Take care.
Thanks,
Bye-bye.
Monica.